Hi, everyone. Good to see you all, and welcome to everyone. So I understand we have our Oxford guest here. Welcome. So glad that you are able to join us. And today, because Bert's connection is not going very well, so I'm going to do some of his role and as well as start my speech. Thank you. So I'm going to start. So first of all, a brief introduction. My name is Julia Wu. I am a principal investigator at the newly formed Harvard Human Immunomics Initiative at the Department of Epidemiology. So I'm working on a lot of the effective immunity, aging, as well as the vaccine confidence topics. So it's been an honor to be able to share with you some of our what we learned during the pandemic. So now I will start to share my screen. All right, can everyone see my screen? Sounds good. All right. So today I'm going to talk about this very important topic of COVID-19 vaccine acceptance. So as it becomes more and more clear that there have been two tales of vaccines. First, vaccines has been considered as a top 10 public health achievements in the 20th century. But then at the same time, it's also considered as one of the 10 threats. The vaccine hesitancy is considered as one of the 10 threats to global health in 2019. This is even prior to COVID-19. What's behind that? A quick review of history can show us that vaccine hesitancy isn't something new. Historical events do matter. And the risk perception in terms of both the disease as well as the vaccine are always going to embed it in historical, social, cultural contexts. And the vaccine confidence or hesitancy do reflect a set of relationships with individuals as part of a community decision. And when we think about vaccine hesitancy, we have to make a differentiation between misinformation versus mistrust. So as we see more and more people lined up at their vaccine rollout centers for COVID-19 vaccination, will COVID-19 fix vaccine hesitancy? And also, as we race against the new variants, do we have enough trust and confidence that most of our population will be able to accept? So back in April last year, my wonderful colleague, historian Emily Harrison, and I have discussed about that. And through a series of historical discussion and analysis, we start to think that a foundation of public trust really needs to be there for a COVID-19 vaccine to be widely accepted, especially if a COVID-19 vaccine comes out at an unprecedented speed. People will need to trust that it has enough safety and efficacy. And then several early surveys have indeed foreshadowed the challenges ahead of us, both in the US and globally. In one global survey of potential acceptance of a COVID-19 vaccine, so it reported wide geographic variation in potential acceptance, and origins of such wide variation was largely unknown, which is important for us to understand and address for the global COVID-19 vaccine rollout. In the US, so the acceptance rate fluctuated between 50% to 70% in the general population. And then also there are variation between different subgroups. It's therefore important to understand the attributes of COVID-19 vaccine hesitancy as vaccine rollout continues and we race against the new variants. So there is a special population, I would say, which is largely ignored when we think about the vaccination. There are very limited data for good reason on COVID-19 vaccine safety and efficacy for pregnant women and children. Yet, pregnant women with symptomatic COVID-19 are at an increased risk for severe illness. Children, although, appear to have a low risk for symptomatic COVID-19, but with similar rates of infection, making them potential transmitters of the virus. And mothers are often key decision makers for whether their children will receive vaccinations. Therefore, it's important to measure vaccine acceptance and predictors among mothers of young children. So here today, I am going to present what we have done as a team, COVID-19 vaccine acceptance among pregnant women and mothers of young children, results of a global survey in 16 countries. This manuscript is currently under review, and I'm presenting on behalf of the full team. So this is the survey that's conducted in collaboration with P-Register, an online forum for pregnant women and mothers. And we conducted during the time of October 28th to November 18th last year. The study objective is to assess potential acceptance as well as potential predictors among pregnant women and mothers of children under 18 years old. This will also provide an opportunity for in-depth listening to women's perceptions, experiences on COVID-19, during COVID-19, and a vaccination attitude. So a brief overview of the methodology. So we obtained responses through this online platform from 1,871 pregnant women and mothers of children younger than 18 years old. We selected 14 countries based on their high cumulative incidence of COVID-19 as of late October, which include United States, United Kingdom, India, Argentina, Philippines, Mexico, Italy, Brazil, South Africa, Spain, Russia, Colombia, Chile, and Peru. In addition, Australia and New Zealand were included for the purpose of references because of low incidence. So, and we conduct a series of exploratory analysis, univariate, multivariate, and subgroup analysis. So to start with the survey design, we hypothesized that the foundation for COVID-19 vaccine confidence really has a same elements as what has been studied in the past for the general vaccine confidence in terms of a conceptual framework, although the specific contexts are different. So namely, the elements of knowledge, information, past experience, perceived importance of vaccination, risk perception regarding the disease in general, and a public trust, subject norm, and moral conviction, as well as the communication and the media. So with that in mind, so we had decided to include around 5 sections of blocks of questions to assess the COVID-19 vaccine acceptance. And then on your left, perceived risk of the virus, and including your past negative experience and exposure, demographics, and then some of the social trust, satisfaction aspect, motivational aspects, as well as the perception of the risk benefit of the upcoming vaccine, namely safety and effectiveness, knowledge on COVID-19 vaccine development, general vaccine attitude on the traditional routine childhood vaccine and flu vaccine. And then the specific questions we asked for vaccine acceptance has a general format is as if a COVID-19 vaccine were safe and available to you, your children for free, how likely will you or your children to get vaccinated or during pregnancy if the vaccine has efficacy of 90%. So we collected both self-vaccination or child vaccinations. And then we use a Likert scale of 5. So likely to accept the vaccine versus unlikely to accept vaccine as our binary response for analysis. So then we had 3 key respondent groups. All participants are now are to form 2 groups: pregnant women, non-pregnant women, and then the third, almost a full sample of women, both pregnant and non-pregnant, who provided likelihood for child vaccine acceptance. So as an overview of what we found, 52% of pregnant women and 73% of non-pregnant women indicated an intention to receive the vaccine, given the 90% efficacy rate. 69% of women overall indicated an intention to vaccinate their children. And the strongest predictor of vaccine acceptance include confidence in vaccine safety and effectiveness, worry about COVID-19, belief in the importance of the vaccine to their country, compliance to mask guidelines, trust of public health agency, attitude toward routine vaccine, and monitoring of COVID-19 news. And as what we anticipate, vaccine acceptance level had a huge geographic variation. They're highest in India, Philippines, and also Latin American countries, and lowest in US, Russia, and our low incidence countries. So a very brief overview of the participant demographics. We have overall the age distributions were quite homogeneous, with mean age of around 34 years. So in general, our participants had an overall higher education level than the general women of childbearing age. And then there's some variability differentiation in different countries in terms of those demographic factors. So 5,282 total pregnant respondents. And then if we look at the variation in terms of geographic region, we can see that for the pregnant women, the acceptance level ranges from 29% to 84%. Above 80% acceptance for pregnant women in Mexico and India, but below 45% for pregnant women in US, Australia, and Russia. So this is for pregnant women. And for non-pregnant women, mothers, also we see a huge variation with a range from 49% to 93%. If you look at the upper area, you will see the bars of India, Brazil, and Mexico, which had above 90% of vaccine acceptance. If you see down at the bottom, you have below 56% in Australia, US, and Russia. And then we will look at the intention in mothers for their children. The results were very similar comparing to the self-vaccination acceptance for those non-pregnant mothers. Above 85% in India, Mexico, Brazil, and below 52% in Australia, US, and Russia. We also had a question asked about the likelihood of increased vaccine acceptance for children 6 months after approval. The results were very similar with the same pattern. This country variable pattern persists after we standardized for key demographics. Overall, the current acceptance level of a COVID-19 vaccine among women, either pregnant or non-pregnant, from most of the high-income countries included in this study are insufficient to reach the community immunity threat of 75%. And furthermore, when we look at not only the acceptance, but also some of the attributes, the results show some more patterns. When we look at the public trust that public health agency would provide accurate vaccine safety information, we see that the same 2 countries, United States and Russia, were again at the bottom, especially the country of Russia, with a huge amount of lack of trust in terms of public health agency providing safety information. And then regarding the perception of COVID-19 as a disease in general, the level of worry about COVID-19, shockingly, in the United States and Russia were similar at the similar level in comparison to that level in Australia and New Zealand, our reference countries. And then when asked about the importance for a majority of people in the country where respondents currently live to get vaccinated for COVID-19, again, United States and Russia fall in the same category of Australia and New Zealand, stating the low belief in importance for mass vaccination for COVID-19. So we saw that a high burden of disease alone may not provide sufficient motivation for pregnant women and mothers of young children to seek vaccination for themselves or their children. And women's risk perception of COVID-19 in the US and Russia was comparable to that in low incidence countries, potentially suggesting a phenomenon of COVID-19 denial. And then we looked at the predictors of COVID-19 vaccine acceptance. Key predictors, as what we overviewed, are those 6 or 7 factors: confidence in the vaccine and a belief in the importance of mass vaccination, confidence in routine childhood vaccine, worry about COVID-19, public trust, compliance to mask guideline, and monitoring of COVID-19 news. So we have conducted both a univariate as well as multivariate analysis for all the 3 outcomes. And the results are all very, the patterns are all very similar, and the results are qualitatively very consistent across all countries. We conducted both the adjusted analysis, also conditioned on country or pooled. The results are all very similar. Again, you can see very, very high crude odds ratio for lots of the variables, and also suggesting some of the correlation between them. And when the models adjusted, the odds ratio diminished to a low level, but again, they remain as the strongest. So this is the case for both pregnant women, non-pregnant mothers, for themselves, and for all mothers accepting for children. Some of the key messages that we crystallized: perceived risk of COVID-19 for the population as measured by worries of COVID-19, belief in the importance of mass vaccination was a much stronger predictor of COVID-19 vaccine acceptance and confidence in comparison to perceived risk of infection for themselves or their children at an individual level. Almost all non-pregnant women with confidence in COVID-19 vaccine safety and effectiveness would accept it for self-vaccination. You can see the high percentage, 97% among the green bar, which is a confident bar in comparison to the 45% of our acceptance, but not as much high among pregnant women. Non-pregnant women who trusted their public health agency had around 90% acceptance. Pregnant women on the country were more open to their providers' suggestions. Very few women who disbelieved in routine childhood vaccines would accept COVID-19 vaccine. As you can see, the very low red bars, among them not confident in the childhood vaccines. Women who did not monitor COVID-19 use had low vaccine acceptance. Women who did not comply with mask wearing guidelines had very low acceptance rates. So then we further analyzed the attribute profiles in US subgroups. So first of all, we looked into our maternal data by looking at the US subset. And then we conduct some of the subgroup analysis by looking at those the acceptance rate, as well as the acceptance level, as well as the attribute level. So if we look at the overall sort of signature profiles, there are some insights coming from the pictures. One is, of course, women without college degree, low education. They tend to have low vaccine acceptance and have low attribute level all across. And then also, we also find that nurses as a group has relatively low acceptance in comparison to the non-pregnant women in general in this particular data. 42% of the acceptance as opposed to the 53 in average. And then by looking at the bars, we can see that it's not because nurses are not worried, they have a perfect perception, but then they had lower than average confidence in COVID-19 vaccine safeties. We conducted further analysis into additional US surveys, one in the general population and the other in the minority groups, African Americans and also Latino Americans. So all these analyses confirm the same key predictors. And then even though those two surveys were conducted at a slightly different time point, they were both conducted in September 2020. So one thing that immediately caught our eyes was the comparison between the different political belief groups. So if we look at the black circles, Democrats versus Republicans, we immediately saw that Republicans, the subgroup of Republicans had a lower acceptance level here, and then really featured by a very low perception of COVID-19 as a disease. 61% worry about COVID-19 among the Republicans versus 83% worry about COVID-19 among Democrats. And also in terms of the belief in the importance of mass vaccination, 96% among Democrats believe that, whereas only 84% had the same belief. And then you see among the female in general, in this general population of the US, female in general has a lower acceptance. They had an appropriate perception of the COVID-19 disease, but they had lower than average confidence in COVID-19 vaccine safeties. And also the same lower level of acceptance occurred in their the low education group. So this is our subgroup analysis among the minority groups. The same patterns were identified when looking at the minority females. Female within their own minority groups, female all tend to have even lower acceptance level than male and then the average because of the lack of lower confidence in the vaccine safety. And then also if, among the blacks, black Republicans had both the low belief, stronger disbelief in terms of the need for mass vaccination and the low worry, as well as the lack of trust because of their minority status. So this is a special vulnerable group, and also Black females. Around 7 to 18% participants across the 3 US surveys did not take flu shots, but would accept COVID-19 vaccine. So this is in contrast to the comparison when we looked into the routine childhood immunization and COVID-19, where women who disbelieve in routine childhood immunization, very few of them would accept COVID-19 vaccine. So last, key influences of vaccine acceptance among women in the US subset analysis, we saw that pregnant women and mothers will be influenced by the medical authorities' recommendation much more than the non-pregnant women's response. But overall, in the US analysis, women just tend to have a low likelihood to be influenced. So To summarize, in this study, we sampled from countries that were highly affected by COVID-19 during that time frame, and we also include 2 reference countries with low COVID-19 incidence for comparison. We saw the consistency among key predictors of COVID-19 vaccine acceptance across all countries, and also furthermore confirmed by the analysis within the US. Some of the limitations were that the survey is always a snapshot of the time and considered as a cross-sectional nature of the analysis. Of course, we need to be careful about generalizability to other countries or regions, although that we receive such a consistent results. And surveys only available in 6 languages, so there might be potential selection bias, and some of the whites and higher educated groups are more heavily represented in the study. And also because the study was conducted during late October, so that's just about the time when the Pfizer vaccine news were announced. So we conducted the sensitivity analysis comparing the pre or post November 9th, which was the day of the announcement. And the results were very similar because we had a short enrollment period. But it's since then, a lot of things have happened because of the new surge of the incidence in many countries, as well as the vaccine rollout campaigns. And a lot of people received the vaccine doses. So vaccine acceptance level will change in different countries, in different subgroups. Nevertheless, here, what our focus here is not just the snapshot vaccine acceptance, but also the attributes which are important to be monitored throughout the vaccine rollout period. So the key recommendation we have here is that denial of the disease, skepticism of the vaccine, distrust of the system, along with pre-existing vaccine attitudes, have together shaped the COVID-19 vaccine hesitancy we observed. So this is consistent across all countries for acceptance of both self-vaccination among pregnant and non-pregnant women, and for acceptance of child vaccination among mothers. The recommendation for improving vaccine acceptance, confidence, and public trust includes that there is room for governments, especially countries such as the US and Russia, that are currently experiencing COVID-19 denial and public distrust, to rebuild confidence as soon as possible in the coming months as vaccine rollout continues. Due to geographic variation in vaccine acceptance, locally specific vaccine programs are needed in this population. And vaccine education campaigns should emphasize the pandemic as a whole and its impact on communities, rather than just limiting to emphasizing vaccine safety and effectiveness. Policymakers must address public denial, doubt, and misconceptions of the disease using clear and unified communications that are immune from political processes. Rebuild vaccine confidence through transparent communication and effective community engagement, especially in those countries, and also to address subgroup specific concerns. And also previous rollout of new vaccines show the importance of community work with sensitivity toward country, local, and subgroup specific cultural contexts. We thank all the study participants for their trust, time, and efforts contributing to this study, as well as a very, very helpful discussion with all our colleagues and our founders. And thank you, everyone.